Hello, Dr. H viewers. Today I am going to give you a in-depth chat about talar liberator subcision. Subcision, or subcutaneous incisionless surgery, was a concept that was first talked about back in 1995. There is a seminal paper that was published by father and son team David and Norman Orentreich, New York dermatologists, and essentially they talk about this technique, subcision or subcutaneous incisionless surgery, in the management of atrophic acne scarring. Since then, obviously, subcision has been sort of a worldwide recognized technique for managing fibrous tethering in acne scarring. It's used in many forms, in many ways. I've also given you a recent publication that summarizes many methods of subcision and the surgical tools that are used to perform them. This was a paper published earlier this year in January 2023 by Venati et al. And this was published in the Clinical Cosmetic Investigative Dermatology Journal. So you can see talar liberator is also one of the more modern techniques that has been talked about in this new publication here, and is one of the safer techniques due to the performance in an expanded plane using tumescent anesthesia that causes less trauma versus other procedures such as no-core needle and a quicker recovery. Please look at these two publications, first of all, to put yourself in the perspective of subcision and its place in the treatment of acne scarring. And once you've done this, you can carry on with the next slides and you will see me drill down in depth on talar liberator subcision, one of the pillars in which we treat acne scarring in Dr. H Consult. Okay, so this slide is a very important flowchart, and it forms the fundamental basis of how I manage acne scarring at Dr. H Consult. So you can see I've highlighted talar liberator in the red box, but just to put things into context, if we look down the left-hand side, you can see a column called scar morphology. Treating acne scarring properly depends on the clinician's ability to diagnose the type of scar properly. Scars fall into various categories. First of all, when I am looking at a person's or a patient's scarring, what I'm actually doing is examining the skin and finding out whether those scars are in the skin or whether those scars are formed by skin that is actually connected down to deeper tissues. Essentially, scars that can be in the skin are things like ice pick scars, rolling scars, and boxcar scars. You've all heard of these type of what we call atrophic or indented scar types. I'm not going to talk about hypertrophic scars. That's a different category. Most acne scarring, over 95% of acne scarring, is indented or atrophic, so I'm going to stay talking about that. Where the scars are in the skin, we tend to need to resurface the skin itself, or if the scars are a type of scar like an ice pick scar or a boxcar scar, we might need to even remove those scars depending on how deeply penetrating within the skin they are and what type of tissue they're made up of. Talar liberator is used to actually separate skin that it itself, due to the inflammatory process of acne, has become adhered to the skin, to the layers of tissue below. And that needs to be released before we can deal with the component of scarring that's within the skin itself. Principles are simple with this kind of procedure. Essentially, where the skin has become glued to the layers below, it needs to be released. Nothing really can be done unless we first release the skin. The appropriate tool needs to be used to do the job, as a partial release won't really effectively help. Release must be complete. It's a little bit like having a ship with multiple anchors. Let's say we have a ship with 5 anchors. If we release just 2 of those anchors, the ship will still not be able to progress in its journey forwards, despite the engines of the ship being at full power. All 5 anchors must be released. And that's where full field subcision comes into play. Tailor Liberator is a tool that can effectively achieve full field subcision and not just partial release of tethered acne scarring. These are a couple of cases that I would like to show you to illustrate what tethered scarring is. As you can see on the first photo with the purple surgical marker illustration, you can see I have drawn circles prior to the Tailor Liberator subcision on the areas of skin which are effectively welded down to what we call the SMAS layer below the skin. I'll show you this in a diagrammatic form in the next few slides. These 2 cases have been predominantly achieved with Tailor Liberator. This was the core problem. Tethering was the core problem here, and Tailor Liberator was therefore the key solution that we employed in these 2 cases. You can see on the right-hand case, the area of tethered scarring is highlighted under what I call shadow lighting or tangential lighting. This is lighting that casts a shadow and shows us the relief of the skin and allows us to easily visualize areas of tethering. You can almost see this star-shaped area that I've highlighted with the yellow line. Once we perform Tailor Liberator, and no other procedure in this right-hand case, essentially the majority of the acne scarring problem is solved. And that is the power of using the right procedure for the right type of scarring. If we had used just laser resurfacing alone, this would not have resulted in anywhere near this level of benefit. If we had used anything else like microneedling or any other surface treatments like radiofrequency microneedling or chemical peels, this wouldn't have allowed the skin to be released. So these 2 patients, it is critical to perform Tailor Liberator subcision or some form of subcision at least to gain this degree of benefit. Essentially, it solved the majority of their problems. Here is just a quick diagrammatic overview of acne scar subtypes, and you can see schematically what fibrous tethering means. So ice pick scars are the scars I was talking about earlier, where we just essentially have a hair follicle that is essentially died and left a tube in the skin. The tube is within the skin itself and not connected to any deeper layers. So if we're going to treat these, we just need to punch them out and stitch the skin across and then resurface the skin. Rolling scars and boxcar scars can be both tethered. Essentially, what's happening here is not only is there an indentation in the skin itself is connected via these fibrous tethers, which are like little fibers essentially, to what we call the SMAS layer. Now the SMAS layer is essentially an acronym for the superficial musculoaponeurotic system. Essentially, this is a layer that overlies the muscles of facial expression, and the skin that is essentially tethered to this layer is where you see large indentations And this type of tethering occurs from really severe acne, such as nodulocystic acne, where we have large cysts or boils under the skin that cause a severe degree of inflammation throughout the skin and the subcutaneous tissue, causing adherence. This diagram really helps us to understand better what we mean by tethering. As you can see, there are 5 layers of the face. The uppermost layer, obviously, and the one we see with the naked eye, is the skin. Underneath that, when you make a cut through the skin, you see that yellow subcutaneous fat. Below the fat, we have the musculoaponeurotic layer. Essentially, this layer, or some people refer to it as the SMAS layer, is a combination of muscles and fibrous tissues that are interconnected between the fat and the skin that allow movement of the face and facial expression. The deeper layer are the retaining ligaments of the face. These are the deep ligaments that hold the face in its overall position and support the position of the face against gravity. Essentially, those ligaments are not dissected in any form of subcision. They may be dissected if you are performing something like a deep plane facelift, but that's certainly not what subcision is. The final layer, the 5th layer, is the bony layer, essentially the fibrous bony layer overlying the actual solid bone tissue itself, and that is where the deep retaining ligaments are anchored to, again, not interfered with by the subcision process at all. So essentially, when we're dealing with subcision, we are performing that subcision in what we call the superficial subcutaneous plane, and that is between 1 and 2, well away from the facial muscles, the retaining ligaments, and the periosteum. So I'm about to play this video, and you will see Tailor Liberator being performed live. You can see the white needle-like object, which is the Tailor Liberator probe, being passed just below the dark grey layer, which is the skin. The slightly whiter band of tissue below that is the subcutaneous fat, and the darker layer below that is the musculoaponeurotic layer. So you can see the subcision is taking place in layer 2, the subcutaneous fat. To be precise, at the junction of layer 1 with layer 2. We are well away from any potentially dangerous territory, meaning that motor nerves, for example, the facial nerve travels between layer 3 and 4, which is well below the level of the whole ultrasound, if you see what I mean. So this is why we never really have, touch wood, any facial paralysis issues with Tailor Liberator. There will be, at this level, some small skin sensory nerves cut, and that's normal, and you can get a little bit of numbness that will last for up to about 3 months, but that usually will restore itself. Blood vessels will also be traumatized slightly, but this bleeding is minimized by the type of anesthetic we use, and bruising will be present, but this doesn't last for too long. So you can see, when looking at this video, the level of subcision with the Tailor Liberator is a very safe level, and it's aimed precisely at these red diamonds which represent the tethering between layers 1 and 3. Without separation of those fibrous tethers, we will not be able to release skin that is severely indented and causing the scarring. This was the thing that I was referring to earlier when it comes to anchoring of the skin. Effectively, Tailor Liberator allows the release of that anchoring. Fibrous tethering and release of fibrous tethering and acne scarring is a a concept that is a little bit difficult to understand. Unfortunately, it's frequently misunderstood by doctors, and that can be frequently seen in these diagrams that are used to represent tethering visually. So you can see on the left-hand side here, the level at which this blunt cannula is being passed is a little bit too superficial. Essentially, it's being passed intradermally above the fat layer. So what the diagram on the left is trying to show you is that by subcising acne scars, you're actually pushing a blunt tool, which you can see has the sharpness of the front of a submarine, and somehow magically popping these very, very tough fibers apart that they have mistakenly presented as being within the skin. So not only is the level of subcision incorrect here, we're not creating holes inside your skin, but the tool is a round tool with a very, very blunt end trying to pop these fibers. So you can see there's a heavy component of misunderstanding by the people that should be really understanding in the first place. Once again, on a rudimentary search of subcision, we can find multiple medical websites showing incorrect understanding of subcision. Here you can see in both these diagrams, it is claimed that the subcision is occurring within the dermis. You can see these fibrous bands of tethering are running between the epidermis, through the dermis, but not through the subcutaneous fat. So remember what I said when I was describing fibrous tethering. I said essentially the skin is connected through the fat with the fibromuscular layer underneath. Here, these guys think that the skin is just tethered to itself and that you have to hack away within the skin, within the dermis, to release tethering, which is nonsense. So, unfortunately, if the people who are trying to explain to you by virtue of these heavily incorrect diagrams are not succeeding to understand the principles of tethering themselves, I don't really see how they'll be performing a subcision correctly if they cannot even understand where the tethering is in the first place. Just for the sake of clarity again, let's look at that diagram. The tethering is represented by the red diamonds that I have placed in this illustration. Between layer 1 and layer 3, i.e. the tethering connects the base of layer 1, the skin, the base of the skin, through the yellow layer, the fibers that form the tethering pass through this yellow layer, and they anchor the skin to the musculo-aponeurotic layer, which is layer 3. So, unlike the previous two slides where you could see tethering within the skin itself, this is not where the tethering is found. It is found between layers 1 and 3, and cystic acne causes the underside of the skin to effectively glue itself through layer 2 with fibrous tethers to layer 3, which is the musculo-aponeurotic layer. So when you saw the video of the subcision, my Taylor Liberator probe was passing underneath layer 1, within layer 2, and above layer 3 to sever these fibers. And that is an appropriate subcision and an appropriate methodology for performing it. If you push a subcision tool through the skin itself, you will cause some significant damage and not release any scarring. Fibrous tethering, as its name implies, is quite difficult to release because of the thick, heavy, fibrous bands that anchor the undersurface of the skin to this mass. Now, subcision as a principle is one that we are all happy as dermatologists with, because it's a well-recognized methodology for treating acne scars that are tethered. However, there seem to be a lot of tools in use that are not going to effectively cut this tethering. Blunt cannula subcision is something you all know is one of my pet hates, and as you can see, blunt cannulas are designed to not cut things. In fact, they were originally designed for aesthetic practice of administration of fillers, and the adverts on blunt cannula boxes were that you don't damage blood vessels or nerves, and you atraumatically can put the filler under the skin, which will lead to a quick recovery of the patient. So now you're going to take one of those tools that doesn't really cut anything or damage anything below the skin and suddenly use it to cut and damage things below the skin. Does this make sense? Not really. I would say, yes, if you use a thick, large one, you could probably successfully release some tethering, but tethering needs to be fully released. Remember the example I gave you with a ship with 5 anchors. If you release 2 of those anchors, the ship remains anchored and will not move despite putting the engines on full. You must release all 5 anchors. To achieve this with a blunt cannula is beyond the realm of believable. You cannot use a blunt tool, and this is why you'll see most people that offer blunt cannula subcision, number 1, will repeat it again and again. Number 2, will use fillers to assist the raising of skin to make the subcision appear more effective. But blunt cannula subcision is unfortunately a temporary suboptimal subcision and will never fully release the acne scar in question. So to cut fibers that cause fibrous tethering, we need a sharp dissection tool. This is obviously quite self-explanatory. To cut anything, you need a sharp tool, hence the word cut. But somehow it seems to be conveniently forgotten in most cases of subcision that are not Taylor Liberator subcision or no-core needle subcision. This tool is called a no-core needle, and it is a much more effective tool to release tethering. It is effectively, as you can see in the top left-hand picture, a small scalpel on the end of a needle, a mini scalpel in fact. The beauty of this is that if you sweep it below the skin, you can easily and comfortably dissect tethering that is adhering the subsurface of the skin to this mass. However, there are a few issues surgically with this device. First of all, it is a small device, which means if you have a large area like the cheek, you cannot easily access tethering without having to re-poke it into the skin several times. This means multiple access points, which is inconvenient. The other thing to bear in mind is that it's also a naked blade. So no matter what you swipe through, it will cut. This is more dangerous. If you are dealing with fibrous tethering, cutting through the fibrous tethering is fine, but we don't want to cut certain other structures. And just having the naked blade on the tip of the needle means we can easily also accidentally pass between layers without realizing that we are doing so. So, in short, yes, an effective tool for dissection of tethering and cutting tethering and releasing scars. However, a dangerous tool because of the naked blade on a short stick aspect. This means much less surgical control and much less ability to differentiate when using the tool between what and what not to cut. So it is something that is much more effective than a blunt cannula, but could in fact cause more trauma and more inflammation and retethering should you start to traumatize the hypodermis itself with the actual blade. Subcision is a well accepted way of treating tethered acne scars. However, tools, as you can see, to perform subcision are multiple and varied. The Tailor Liberator is one of these tools. It is my preferred tool for a number of reasons, and I will explain these. You can see on the right hand side we have a view of the whole tool. As you can see, it's a handle with a long screwdriver like appearance. Essentially it has a tip which can be seen on the left hand side, which looks like a flat blade screwdriver with two notches. In these notches are hidden the blades. The prongs or the flat tip is actually blunt, but the notches are where the sharp blades are. The design of this is made such in order to harness or gather the tethering within the notches, and the tethering to be funneled towards the actual notches where the sharp blades lie, and the fibrous tethering is effectively severed by the sharp notches. The tip of the tool is blunt, so should you poke it into any structure that you do not wish to dissect, unlike the naked blade of a no-core subcision tool, a no-core needle, it won't just slice through anything. So here you can maximize gathering of tethers as well as not causing any damage to important structures that you do not wish to damage. The fact that the tool is rigid and long allows a single entry point on the side of the cheek or on the hairline, for example, if you're dissecting forehead fibrous tethering. And this allows a single access point per region. This is obviously important in terms of minimizing access ports and trauma. The other bonus is, because the tool is rigid, we can sweep it from side to side quite safely without cutting anything, unlike the no-core needle, which if you sweep from side to side will result in cutting during each sweep. And essentially making sure that there are no residual tethers that need to be dissected. So this is an excellent way, which you have seen in previous videos that I've shown, to illustrate to the surgeon performing the procedure that he has indeed completed the procedure to a satisfactory endpoint, i.e. that there are no residual undesirable fibrous tethers left and the skin is fully released where it should be. Let's talk a little bit more about the Tailor Liberator tool itself. As you can see, when we are performing the subcision, when we advance the tool, it cuts. Now, the advancement of the Tailor Liberator probe will cause gathering of the fibrous tethering in the notches, and at the base of the notches, the very narrow V-shaped end of the notch, it will cut the tethers. The prongs are blunt, so this allows the tool to be advanced safely and come to a halt when any major important structures are lying in front of it. So this makes tethering the focus of the dissection, and larger structures, important structures that need to be preserved, are indeed preserved. We can see that the other sides of the tool are blunt, so if you were to move the Liberator from side to side, you wouldn't cause any trauma or dissection. If you reverse the Liberator and retract it, you won't cause any trauma. The tool's design with a large handle allows for good control of the probe and high stability. If you can imagine, a no-core needle has very, very poor stability control, as you are using essentially a finger and thumb to either hold the needle and manipulate it, or more commonly just bolting on a syringe as a handle and then using that to control the position of the needle within the skin. That doesn't allow for great tactile feedback. Essentially, when you use a Liberator, you can see the position and orientation of the tip can be verified with the notch in the handle, and that allows me to know which side up the Liberator is within the skin and know the orientation of my probe at all times. You've seen sometimes I've filmed it on ultrasound guidance as well to show you how it essentially stays precisely within the right plane at all times. The no-core needle is a sharp tool, which means it can easily pass between planes, and if advanced into important structures such as the facial nerve or the wrong plane, or indeed the angular artery, or something that is essentially something that you do not want to dissect, you won't have much control in not cutting those other structures. So, very important, a safe tool should be used for subcision, and an effective tool should be used for subcision. Safety profile of Taylor Liberator is evident over the last 8 years. We have probably, counting since its inception in 2015, performed well over 1,000 cases now. Our last count in the last year has been just over 200 cases performed with the Liberator. We've had 0 facial nerve trauma, 0 problems with any long-term hematoma type issues or dangerous tension hematoma type issues. There are only 1 or 2 in the last year that have decided to drain. We have 0 infection problems. I used to prescribe antibiotic prophylaxis when I started the procedure, but given now 8 years on and the amount of cases that we've performed, I see no reason to cover with antibiotics unless someone was to develop a large blood clot, in which case I'll probably drain it and then just give them a week's worth of antibiotics. Other than that, you can get prolonged swelling. Prolonged swelling is any swelling with the Taylor Liberator that persists for more than 3 months. But MRI scanned, we've MRI scanned many of the cases, 20 cases this year, where we felt swelling was prolonged, and by 6 months, all inflammatory process in the cheek was seen to have completely subsided. So, in essence, we've found that the safety profile of Taylor Liberator has been proven over multiple statistically significant amounts of cases performed in my center in the UK, in Utah, in the US, and in Kuwait, where my 2 colleagues essentially perform similar numbers of Liberator procedures. And combining those procedures between us, we have not encountered any significant complications. I would say that sensory nerves have been a temporary issue. So when we do Liberator, we expect to get some level of numbness in the subcised areas, but in essentially over 98% of cases, this resolves by 3 months. I have had a couple of cases where there is some complaint of aberrant sensation in certain areas that has gone on for longer than this, but it certainly causes the patient no functional abnormality or no problems in their activities of daily life, apart from feeling a slight numb area if they were to touch their face. And this, as everyone knows, is very common when dealing with surgical scars or sites of surgery, to have a little bit of numbness and change sensation around the area where the surgery was performed. So, in short, I believe it is an ideal tool for safe and repetitive performance of subcision in acne scar patients, offering the surgeon a high degree of control and a high degree of surgical efficacy in the subcision. Very, very important part of this talk now, essentially. Does fibrous tethering recur? One of the big problems that I see every day is misinformation, especially in the field of acne scarring. Fibrous tethering will only recur if there is an ongoing inflammatory process. So, this is a well-known phenomenon in medicine. It's not just something that's present in acne. So, let's have a look at, for example, inflammatory bowel disease. Inflammatory bowel disease, patients that suffer with active inflammation around the bowels will get tethering in that they'll get fibrous adhesions between their bowel. Surgeons will have to go and then dissect these adhesions, funnily enough, not with filler or blunt cannula, by going in there and manually pulling the bowel apart. But essentially, that fibrous sticking together of the bowel has been caused by inflammatory bowel disease. Or in females, you can get pelvic inflammatory disease following various sexually transmitted infections. And this also results in fibrotic adhesions forming within the abdomen. So it's definitely not an unknown issue. We see this all the time. In order for these fibrous adhesions not to come back, the inflammatory process must be solved. So in the case of inflammatory bowel disease, that would mean stopping the inflammation with steroid treatments, with systemic treatments that are administered by your colorectal surgeon or gastroenterologist. When it comes to acne, it means stopping acne. Now, this will be undertaken in many different ways, but anything from hormonal control to oral isotretinoin or Roaccutane. Once the acne is over, there should be no reason why fibrous tethering should recur. However, I often find patients asking me why they have had to have repeat subcision procedures in other centers, because essentially they've been informed that these repeat procedures need to be performed because tethering will recur. This, I'm afraid, is incorrect and misleading information. If the patient has been cured of their acne but still has acne scarring, there is no need, if the subcision is performed appropriately, there is no need to repeat the subcision process. There is no need to administer filler in the area to help prevent retethering, because retethering will not recur. So, we have shown this in all our Liberator procedures by performing ultrasound in procedures several months after Liberator to show whether there has been recurrence of the tethering, and it cannot be seen if the patient has had no further inflammatory process such as acne recurring in the cheek. And this makes sense. It would make sense in any other area of medicine, let alone acne and dermatology. So This, I'm afraid, patients, is something that is used as a cover-up to explain why subcision procedures that are ineffective, such as blunt cannula subcision, need to be repeated and again and again. If the subcision completes the job of releasing tethering, if you don't have any more acne, your tethering does not recur. Full stop. Just to further explain the logic of this filler in stopping tethering recurring nonsense. First of all, we've seen that the filler needs to be applied below the skin in the fat layer, if this was to be the case. For the filler, if you have successfully released the tethering, the filler won't really remain in a fixed position in that layer. The only use for filler in the treatment of acne scarring is to allow expansion of the skin itself. So the filler has to be injected within the skin, not below the skin. If you inject filler within the skin, you can expand the dermis where you may have areas of atrophy or indentation, and this will result in a temporary cosmetic improvement. It will not, however, release tethered scars, and putting filler in an area where we have released tethering is pointless because the filler will not remain fixed in that position. So using filler to stop tethering is not an appropriate medical explanation for why filler is used in scarring. Using filler to improve the cosmetic appearance of scars that are atrophic within the skin in order to make them expand up and look flatter is the reason why filler is used in scar management in acne scarring. So here we are, sort of harking back to those two cases I showed you earlier to confirm the principle we just discussed in the previous slide. These patients obviously had talar liberator subcision. Here we have two male patients, both having the Liberator procedure. The patient on the left is 3 months post-subcision and laser resurfacing. The laser resurfacing was just done for the more superficial component of his scarring. 3 months after talar liberator subcision, and we don't see any reformation of tethering. So that is good proof that if there is no active acne, then tethering won't reform. I can't imagine at any point, if this patient doesn't go on to have acne in the future, that he should wake up one day having tethering that has somehow come back. That is not going to happen. It's beyond the realms of imagination. The case on the right, likewise, as you can see, we have subsided. Things have settled down a good 2 weeks afterwards. He may have a tiny bit of atrophy left within the skin, but certainly that tethering is not going to just suddenly reappear. It's enough time to have allowed for significant subsidence of any peri-procedural or inflammation associated with the procedure to have subsided, and you just can't imagine that if this is now done properly, things will recur. And now if you go to the actual website itself, you can see cases where we've performed talar liberator in the past, 10 months, over a year onwards, and no evidence of tethering reforming. So once again, I reiterate, if subcision is performed appropriately, we will not have re-adhesion of the hypodermis with the SMAS, and tethering won't recur. The only reason why it may recur is if there is a similar ongoing inflammatory event, i.e. recurrence of acne or poorly controlled acne, that new scars and new tethering will recur. One of the problems with performance of subcision is that people associate it with quite a significant amount of bleeding. And also, when using a device like a Taylor Liberator, when you see a procedure being performed, one gets the impression that it may be quite painful given what's actually happening. However, these are only impressions, because the use of tumescent anesthesia allows us to perform this procedure completely painlessly. When I say completely painlessly, obviously the prick of the anesthetic being administered will be felt. However, once the procedure is underway, the patient feels nothing but pressure and movement. There is no pain. And once indeed the anesthetic has worn off, the patient will not feel any post-procedural significant pain or soreness. The reason why this is that the anesthesia is effectively achieved with tumescent. The tumescent anesthesia is a high volume anesthesia. By adding bicarbonate to the anesthesia, I'm able to inject it without too much of an acidic sting to the anesthetic administration. The adrenaline within the anesthetic allows the bleeding in any subcision procedure to be minimized. This use of tumescent has allowed us to perform hundreds of cases of subcision now with minimal hematoma events. In the last 200 cases we performed this year, probably, like I say, only a couple of hematomas that merited draining. And these are hematomas that are in the subcutaneous layer, so they don't warrant any emergency drainage. They are non-tension inducing hematomas. They don't cause any compressive effect on structures. The Kenalog that I add in the tumescent solution also allows for suppression of peri-procedural inflammation. Not that this would cause any adherence or readhesion of the skin, but it helps allow a much more rapid settling post-procedure. So I tend to include a small amount of steroid in my tumescent solution for that reason. So here you have a video of myself performing Taylor Liberator subcision in this young lady. You can see the single entry point near the hairline there, probably about a 3 millimeter oblique entry point through the skin there that allows for a nice seamless healing of the entry point. Here you can see this side-to-side motion in the purple line demarcated territory. That shows that the subcision has been complete and full field in that area. Now, people sometimes when they watch these videos think, oh, well, are there any other important structures that are dissected there? You can see that the superior line just below the eye there, the purple line, and the abutment of the probe against that line is where the zygomatic cutaneous ligament is. Medially, we can't get past. You see the probe stops at the medial purple line in the nasolabial fold and mandibular area, because those are ligamentous structures that cannot be traversed by the blunt flat blade, by the blunt end of the Taylor Liberator probe. So you can see important structures are not going to be dissected. It's actually pivoting over the sort of zygomatic ligament McGregor's patch area. So we're essentially running the probe under the skin, at the junction between the skin and the subcutaneous fat. This is a level 2 undermining of the cheek here, and essentially that preserves any deep suspensory ligaments. Those will not get ruptured. The superficial Fibrocutaneous retinaculi will reconstruct over time. They are just fine adhesions that are natural that will reconstruct. The fibrous tethering, however, will not redevelop itself because that essentially is a pathological feature. So blood vessels, fibrous blood vessels, sensory nerves, and fibrocutaneous retinaculi that are formed between the cheek, the lower surface of the skin, and run through the subcutaneous fat will reform. You will not, however, get further tethering because there's no inflammatory process. Swelling is variable depending on how much tethering was present. People with a lot of fibrous tethering between the scars and the SMAS and many areas of it will have a slightly prolonged low-grade swelling. People with just small isolated areas of tethering where we can limit the subcision to those areas will find that their swelling and recovery will be quicker. So essentially there you have the procedure in motion. This slide is designed to show us sort of in an overlay format the position geographically of where we are performing the talar liberator subcision in the buccal area. So one can see here that the territory of the procedure is quite safe, as any plastic surgeon performing any facial skin undermining in this area will realize that in the superficial subcutaneous plane, there is nothing to worry about in terms of nerves that are going to cause any motor dysfunction or significant blood vessel type problems that are going to occur and cause large hematomas. You're not at risk of causing any tension, hematoma or bleeding problems. So essentially, you're very safe in this region. However, it is the essential region to subcise when it comes to a lot of acne scar patterns. The other thing to bear in mind is that deep retaining ligaments are between layers 3 and 5. So being in layer 2, we are not anywhere near those. So essentially, the anatomical structure of the face and its suspensory ligaments is undamaged. Yes, there may be some swelling due to trauma, and the more tethering there is, the longer one could expect that swelling to last. But this is a low-grade swelling that will eventually settle. As operation-related trauma is something that is finite, in the same way that someone having a rhinoplasty or plastic surgery of the nose wouldn't be able to expect to see the complete shape of their nose in an accurate way until around about month 3 or even a little bit longer, because the soft tissue swelling would take a fair amount of time to subside. So yes, it's absolutely normal to expect some degree of slight swelling that will persist for a few weeks in the area of liberated subcision, but this swelling will subside. And the MRI scan studies that we have performed show that this swelling then goes on to subside completely, as there is no increased uptake of contrast that would indicate any persistent inflammation post 6 months. This schematic anatomical diagram, in which you can see the layers of the face represented again, illustrates the safety of the plane that we're performing the subcision in. As can be seen, the main aggregates of what we call fibrous retinaculi that allow for mobility of the face, but also preservation of the facial structure and anatomy, are preserved. We are below the zygomatic cutaneous band. The sort of zygomatic ligament McGregor patch area is, we're actually pivoting above that, with the Liberator. You can actually see that in the video that I've just shown you in a slide or two before this one. We're traveling superior to sort of above the anterior masseteric ligaments, and that allows us to make sure that we are not at all transecting these main ligament aggregates, which means that obviously there's no trouble with the deep retaining ligaments because we're well out of range of those, and the main bands that help connect the skin in the superficial layers are also avoided. Obviously the motor nerve, the facial nerve, is below this mass, so we are well away from that, which is why we never really have had, well, we have had 0 cases of facial nerve damage throughout the history of 1,000 plus Taylor Liberators performed at Dr. H clinic. The parotid is also safe, and we've had no issues with parotid damage. So you can see that it's a surgical safe plane. The addition of tumescent and the use of a device like the Taylor Liberator allows repetitive, safe dissection of this area to be performed, and with a very, very low complication rate. So essentially, I have myself performed Taylor Liberator subcision since 2016 officially. I mean, 2015 was when I started doing some cases, but we started to essentially launch it in 2016, where we made it a sort of go-to part of our acne scar management service. Very important to understand that a great deal of significant acne scarring cannot be managed without a procedure like this. Subcision is one of the pillars of acne scar management. If we miss out subcision, then we are missing out any effective management of tethered scarring. So given that numerous patients have suffered with acne severe enough to result in this tethering phenomenon, to not perform subcision would be to not effectively treat their acne scarring. And this is why a lot of centers that are more in the sort of aesthetic sector rather than the derm surgical sector will not be able to effectively manage acne scarring, because they are failing to understand the different components of scarring, i.e. the subskin component, the component within the skin, and as a result, just broadly applying one device or therapy that you have cannot really solve all types of scarring effectively. Thank you for taking the time to listen to my information on Taylor Liberator subcision. Like I say, it's a very important pillar of what we do in the management of acne scarring. Essentially, I'm just going to round off this presentation with a few conclusions, and hopefully you've been able to see how big a difference we can make to the lives of acne scar patients when we appropriately assess their scar type and apply the appropriate surgical methods at our disposal to manage the actual scar problem appropriately. I think the most important thing to consider is that subcision is a known, reliable pillar of acne scar management. And that's because fibrous adhesion of the skin causing indentation within the skin is a phenomenon that has been known about over the decades. So the goal of all subcision is the same. Tailor Liberator is merely a device or a tool to perform subcision with. So if one was to perform subcision with a no-core needle, a Tailor Liberator, SurgiWire, or another dissection probe of some type, the goal of the subcision would be the same: to release the hypodermis or the underside of the skin from the SMAS layer, which is universal. So Tailor Liberator subcision is a tool that we use to achieve this, and it is a tool that proves to be effective and consistently safe. The degree of safety can be evidenced over the amount of cases that have been performed worldwide in the 3 key centers across the world that perform it. And that essentially shows a once-off subcision procedure that leads to long-term release of these scars, permanent release of these tethered scars, and with minimal issues in terms of complications like we've discussed. So would I say that it is an essential part of my practice? Absolutely. Is it an essential part of any practice that takes acne scarring seriously? Definitely yes. Thank you very much for listening today.